Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. Because we have another great guest tonight.
We have another great guest, and I'm sure you're also excited because we're wrapping up a series on nerve, and I'll probably owe you at least some kind of series of sportsy kinds of things.
You will. And I think we just disparaged our guest because she's really not a guest. She's really like the third wheel, kind of.
She is a recurring guest, third wheel, really the glue that holds the whole show together. If we don't have Macy on for a few episodes, people start to wonder what's going on. So, welcome to the show, Macy.
Thank you both. I think you're giving me a little bit too much credit, but I'm happy to be here.
Well, you have a lot of fans out there. That is clear.
Yeah, very flattering and really cool that you brought me on. So very appreciate it.
I had a great serendipitous meeting with your family this week, and I think I already mentioned it on the air. But I was down in Alabama at the turkey trot, cheering on my family because I'm too injured to run. And I met your husband, who I know, and your son, and most importantly, your dad, and they were all awesome.
That is so random to me. I was under the impression that you ran it with Kylie.
Can I ask a favor? Somehow or another, when you turn, your volume is changing. Like it did it the first time, so just stay really still.
Sorry.
No, you're. It's not.
Let
It's
me
not.
shut the door. Hang on.
No, it's just a technical thing.
Do we have to start over now?
No, just
Start with the that was so random.
Yeah. Like
yeah, that was so random that you ran into my family in our mutual hometown of Birmingham, Alabama this past weekend.
I know. There was 1,500 people at the turkey trot. I was a fan. I was not running, but I know that I think your dad and is it your brother did the 10K?
My brother-in-law, yeah. So was it the Achilles tendonitis or the knee arthritis that kept you back this time?
Arthritis. That's a bold proclamation.
So wish me luck. I'm having my knee scoped tomorrow.
Oh, good luck.
So hopefully we check off one problem, and then just the old age in general will be the only thing keeping me down.
There's no sign of arthritis than being an arthritis denier by getting your knee scoped.
Well, it's all about ratios. If the ratio of meniscus tear pathology is greater than the arthritis pathology, then I'm good.
Let's just let it be told that Chuck practices evidence-based medicine, but he doesn't want any part of being in evidence-based medicine. He's signing up for a knee scope and praying that he doesn't end up with a unicondylar or knee replacement or some other craziness.
This is a prayer. I will say it right here and right now, but there is a meniscus tear, so let's just hope it helps.
Well, good luck tomorrow.
If you hemorrhoid all of us, there'd be at least one meniscus tear.
Yeah, your ages put together are probably less than mine, so I don't need to talk to you guys about this.
I'll stop talking junk. I operated on a patient recently who is far older than anybody on this on this episode, and he told me, he's like, when can I start to exercise again? I exercise 3 times a day for 20 minutes. I'm like, hey man, that's awesome. Good for you.
I've told you my latest. I think I have been a lifelong hater of early morning exercise, and now I get up at a ridiculous hour to get on the bike or do something. It means I'm old.
What prompted the change?
I can't sleep as well as I used to, and I can't exercise when I'm tired at the end of the day.
Got it. Well, welcome to the club, Chuck.
At the end of the day, it's like I'm done. My gas tank is on 0.
I know. All right, we should jump into the actual reason for our getting together. So Macy, this is the 4th of a 4-part series on radial nerve injuries, radial nerve palsy. The first episode was a general discussion, and then we talked about radial nerve transfers, and we talked about tendon transfers, and we wanted you to bring it all home and package it up for us and explain how you think about these. So Chris, I don't know if you want to start off the questions for Macy, and I'm sure you want to talk to her about nerve transfer rehab.
Well, yeah, no, so Macy, I'm trying to remember the exact scenario we presented a few episodes ago, but let's change the details slightly. So say you have somebody who's, middle-aged like Chuck, sustains a fall, has a mid-shaft humerus fracture that's closed, and is treated operatively. Before the surgery, there is a noted radial nerve palsy. The surgeon did not expose the nerve as part of their surgery, treated the fracture. X-ray looks beautiful, but the patient, again, still has a radial nerve palsy. They're in the office. They come to our complex nerve clinic that you and I collaborate in and say they're 6 weeks out now. And how do you approach that patient? Because inevitably I'm going to leave the room and say, Macy, I'd love your thoughts because you're the expert on how to help us decide what is best for this patient.
So first I would join you in a collaboration of, is this surgical or is this not? And so if they're saying, oh, it's getting better at the 6-week mark, correct me if I'm wrong, you might want to observe it. But if it, you likely would order some nerve studies and then have them come back after those are done. But I'm going to make sure that this patient is comfortable. They have some sort of splint that's going to support their wrist and support their fingers if needed. Make sure that they keep their joints supple. A lot of times these patients don't need formal therapy at this point, just some sort of supportive splint to keep their wrist in extension. And then I would meet them again when they come back after their nerve studies. And then you would make that call whether or not they're a candidate for nerve transfer or tendon transfer. And a lot of times we think, okay, they're more of a tendon transfer candidate. Okay, they're more of a nerve transfer candidate, either personally or physiologically. And
so I'm gonna stop you there and say I don't make that call. We, meaning you and I, make that call together. Or if I'm
right.
with one of your other hand therapy colleagues, I'll make that decision with them. I think that you've said a couple things. I'd love to know your thoughts, just your gestalt on who you think is going to get better on their own. Because I don't think it's just me or the surgeon who's making a decision on who is a surgical candidate versus not. I think that there are a lot of clues that you as therapists pick up on to say, hey, this is probably going to get better. I don't think that call is exclusively ours as surgeons. And then the second question, I'm like Chuck now. When you talk about splints, can you tell me a little bit how you think about like a thermoplastic versus a Benic? Because I know a Benic is something that a lot of patients often benefit from.
Sure. So I will always recommend a Benic first for comfort. So it's softer. I think it's more functional. If it's more comfortable, people actually wear it. The downside of the Benic is that you have to pay out of pocket like 120, something like that out of pocket. And you can't get it same day. So I have to take measurements and submit some paperwork to the company, and then it comes within a few weeks. The idea of getting something the same day across the hall, but the therapist can just whip out a custom brace to support their wrist and fingers, is very appealing to patients, along with the fact that that is often covered by insurance. Even though a custom one made by me or my colleagues would be more expensive than the Benic, if the patient knows I can get it today and it's likely going to be covered by my insurance, that's often very attractive to them as well. A lot of times patients have both and they can alternate between the two if they have the resources.
So when I think of a Benic as a congenital hand surgeon, a Benic to me means a soft thumb spica. What does a Benic in this situation mean?
It's the same company as you're used to with the congenital population, but it's just a dorsal-based, soft radial nerve palsy splint that it's not hard, right? So it's just more comfortable. It keeps them in the same position. And it's moldable, like it comes in and then we mold it either in the microwave or in a bit of warm water, mold it to them. So it's just more comfortable because of the material.
So it holds their wrist in neutral is what you're saying. Does it do anything with the MP joints?
It actually holds their wrist whatever we want it to be. So I'll probably put it into 30 degrees of extension and then MP joints and thumb in full extension. And then it allows them to have active finger flexion with a little bit of passive extension when they release an object. So it's just as functional as the thermoplastic one.
Awesome.
I do want an answer to the first question I asked you, but Chuck, we would be remiss if we didn't talk about our friends over at Practice Link before we got any further.
I agree, and I was looking forward to sharing my appreciation for Practice Link because the Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com. Now, Macy, I mean, it's pretty amazing that you got to hear us do that live. But
That
so
was
let's
very
get.
special. Thank you.
I'm sure you enjoyed that thoroughly. Let's get back to the question I wanted an answer to, if it's possible. Just are there any clues that you get on your examination, your assessment about who early on who might get better without surgery?
Sure. So if we're talking independent of what nerve studies show, this is just my
Correct.
clinical assessment
Mhm.
in the clinic. Their exam. So I have a piece of paper that has a radial nerve exam, and I go from proximal to distal, and I do all the manual muscle testing. Takes a while in detail. And then if they're starting to show that things are coming back, then sure, I'm like, do you want to operate on this right now? Is it going to be more optimal if we just wait for the natural recovery to come through? So it's very much based on a clinical exam, starting from the top and then monitoring that from when you first see them, documenting it, and then their next follow-up.
Got it.
Yeah, that would be like the most obvious objective clinical finding.
Now, you mentioned on when you talked about how we decide together about whether somebody's better off with nerve or tendon transfers if they end up being a surgical candidate. You mentioned personality and physiologically. So can you go a little into some detail about maybe personality or?
I want to be as politically correct as I should. But I think that there's sometimes people who get it and people who don't, and sometimes they just really understand the anatomy. They understand what's going on. They have realistic expectations of what you're telling them. And sometimes people, you just have an inkling that they might not be the best people to comply, whether that might be behaviorally, socioeconomically, just various person factors that you're like, would they be able to, have the resources, the motivation to go through the extensive nerve transfer rehab, because that's a huge expense and a big commitment on the patient's end. So nerve transfer is kind of like you're in it for the long haul. Tendon transfers is, as you know, a quicker fix, but also has its challenges as well. So there's no perfect, easy way out.
Now, the tendon transfers, what, for those of our listeners that are not therapists, what does that rehab look like for a tendon transfer in terms of, you mentioned things like intensity of time, like the re-education part of it, like how tough is that rehab?
I think patients can make it through the first 6 weeks, they'll be fine.
Can you start over? It's weird. Your mic is like, when you start, it doesn't sound good, and then it comes normally. So
Should I take these
no,
off?
you're perfect now.
So weird. All right, I just won't touch the computer. What was your question?
So it was about what the tendon transfer rehab looks like.
So I think that if patients can make it through the first 6 weeks following a tendon transfer, they're going to be golden. It's the hardest part, because the way I educate patients about this is, your muscles have been realigned to help create this pull of the muscle and tendon unit to facilitate wrist extension and finger extension. And you really want to maintain that nice tight position for at least a month in a splint to keep it tight. If you accidentally or purposefully let your wrist dangle, let it drop into flexion, let your fingers drop into flexion, you could lose that tension and you might overstretch the transfer. So I always try to scare them a little bit in the beginning so that they really buy into the idea of full-time splinting for a month, because full-time splinting for a month is very burdensome. And so if they buy into it, I think that they'll be fine. So anyway, it's the first month is easy in the sense that all you have to do is wear a splint. Not a lot of exercises other than actively and passively flexing the finger IP joints if they're stiff. And then they come back around a month, and then that's when you start tendon transfer training. So typically you would do very gentle, active wrist flexion in a gravity minimized plane with attempted active finger extension, gentle pronation with wrist extension simultaneously, and kind of guiding them through very gentle exercises. Probably see them once a week for 2 or 3 weeks, and then every other week, and then let them be by 10 weeks, 12 weeks, they're done. Nerve transfers, as you know, can be a year. So it's just a different lengthy process. Go ahead.
Are there any factors which you see which affect the outcome of tendon transfer and re-education or are radial nerve tendon transfers just pretty good?
I think they're pretty good. I think it's more difficult to get optimal positioning of the MP joints with splinting. So typically the wrist is pretty solid. But to get full MP extension, keeping the PIPs free is very difficult, even for the most seasoned of splinters. And if they lose any swelling or they put a strap on the wrong way, it can shift and then their MPs aren't supported enough. And a lot of times they fall into a little bit of flexion and then they're like that for 3-4 weeks and then they can't get that active 0 degrees extension back. So I think that difficulties with splinting can be a problem. Patient understanding of the diagnosis, their health literacy plays a big factor, compliance with the splint, all that kind of stuff.
So what is it about nerve transfer therapy that is so different from a re-education perspective, aside from the frustrations of having to wait, 6 months or 4 months for the lights to come on in terms of the signal to reach the muscle? What makes that re-education piece so much harder? Because fundamentally, it's, we try to choose the nerve transfer donors based on something similar to the tendon transfer donors in terms of synergism.
Yeah, so I think that a big part of it is, again, I've said this word a lot, but patient understanding of the nerve transfer. There are countless times where I've seen patients ongoing for months and months and months. And every time I see them, I say, "What's your donor? Tell me what your donor is." And they're like, "No, what?" They really struggle to understand that relationship. And so I think even my, quote, brightest of patients really still struggle in understanding that it's a complex thing. And so I think that really understanding what is driving the recipient target muscle. And so once they have that, it's easy. You're just teaching them what to strengthen from a donor perspective, and then what recipient muscle you're trying to activate and coupling those two motions. So a lot of times therapists get really freaked out by nerve transfer rehab, but if you really understand the anatomy and what the patient's supposed to be doing, it's really not that difficult.
So wait a second. Now you got me confused. You're telling me that
Oh God, what did I say?
No. You're telling me the patient needs to understand what Dr. D has done with nerve transfers? Or because I don't understand. Or does the patient just need to have a sense of what muscles to strengthen on both sides of the forearm?
Yes, that's what it needs to happen. So I'll often write the referral and copy and paste the surgeries from the op note in the referral, and they'll see Dr. D's list of 17 different things that were done, and they're really overwhelmed. I'm like, "Don't worry about that. Just ignore it. Here's your donor. Here's your recipient. Understand those two things, and we're going to be solid." But as simplistic as I just made that sound, it's still some difficult for patients to get.
But don't they need to understand that for tendon transfers anyway?
Yes, but I kind of view tendon transfers as more of a static transfer where I believe that if you have really solid splinting for a month, it's going to get there. Just keep it tight. And then, yes, those tendon transfer exercises are going to augment the motion, but I don't believe that donor strengthening is as important in tendon transfer rehab as nerve transfer rehab. Again, this is one therapist's opinion, but I feel strongly about it.
Right. Well, I mean, you see a high volume of nerve injury patients between our orthopedic complex nerve clinic and all of the wonderful plastic surgery colleagues we have at WashU who also will send their patients to Millikan. So I have a question for you. Do we ever over tighten tendon transfers?
No, not at all. I don't think so. In fact, I'm typically pretty conservative with my treatment of tendon transfers, meaning that I would keep them in a splint for longer because I never really see a downfall of keeping it tight for longer. So I don't ever think that that's an issue.
All right, let's go back to nerve transfers. I'm a little slow. So you're telling me that the primary focus, and maybe I just want to be very clear, is strengthening the nerve, basically the donor muscles? Because you obviously don't want those to lose strength. And secondarily, you're working on the recipient's muscles for the nerve transfer, but really that's just a time-based problem, right?
Exactly. So there's a wonderful article written by my colleague Lorna Kahn called the ADAFRA approach, the donor activation focus approach for nerve transfer rehab. And so it's all about the beginning phases, flooding the donor, 20 reps every hour, just really giving more and more activation to the donor, which will subsequently give more electrical activity to the recipient. And then in the case of median to radial nerve transfers, let's say you get a twitch of your recipient at 4 to 5 months. At that point, you start trying to do more active motion of the recipient. But in that first while you're just waiting and waiting and waiting for the target to come back, you not only do donor strengthening, but you combine donor activation with recipient target muscle activity passively. So for example, I might do like resisted wrist flexion and using my contralateral hand passively extend my MP joints. And then eventually just doing the recipient activation. And I think that education is important to help patients understand that synergistic movement that has to happen together in order for the recipient to happen independently later.
So when should we start the donor activation or the donor flooding? Like when should that start after a nerve transfer?
A lot of the literature out there talks about a prehab appointment to really start doing that before surgery starts. But if I'm being honest, that never happens really. I think that as long as they get to that point within the first 6 weeks, that's great. Just even for patient understanding and patient receptivity, that first appointment is often very overwhelming, but you go through a lot of important things.
Does electrical stimulation play any role in the rehab of either tendon transfers or nerve transfer patients?
I would say more so with tendon transfers because I'm sorry, nerve transfers. Because tendon transfers, you're trying to strengthen a muscle tendon unit versus nerve transfers, you're strengthening the nerve to go to the muscle. I don't use it that often, but I definitely think it has a role if you're struggling to find anything, or for example, like if patients just really can't, in quotes, find their donor, find their muscle where like it's been so long since they have extended their wrist on their own, they just kind of really struggle to like think about that activity, just like is lost from their brain. Like the thought of wrist extension is just foreign to them. So then you put electrical stimulation on their dorsal forearm and then it actively comes up on its own and they're like, oh, there it is. Okay, that's what I'm trying to go for. So it's a nice patient education tool.
So when you rehab our patients after tendon transfers, you said that after about 10 weeks, they're pretty much finished. When do you think their function starts to plateau from after they've left therapy, or are they seeing a plateau and kind of got what they got by the 3-month mark?
Yeah, that's kind of what I was thinking, like the 10 to 12 week mark. If they still haven't gotten their recipient muscle activation, then it's probably what it's going to be. I've had very few patients for the radial nerve example where they struggle getting that MP flexion back, which I don't really think is a problem. Like as long as they get their extension, I'm pretty confident that flexion is going to come back in time if they're stiff. But like for that particular patient, I don't think it's you get what you get. I think that's going to come back in time, but it's more related to the target recipient muscle activation that we're going for. So, for example, if it's 12 weeks out and they can still only obtain negative 50 degrees of MP extension actively, I'm not so convinced they're going to continue to get it.
That makes sense. I would say that I share that belief. Now, to clarify again how this compares to nerve transfer timing, when does a nerve transfer patient, like in this situation, when would you expect them to plateau? Is it 24 to 30 weeks, or is it even longer?
I think it depends on the transfer and how long, the donor was to the recipient. But I would say it would plateau 14 to 18 months. Dr. D, is that on target with what you were just thinking.
Yeah, I was going to say 15, 18 months.
Oh, look at that.
It takes a long,
Look at
yeah,
that.
it takes,
It's like we work
yeah,
together.
it's like we work together. I saw a patient recently who had a lot of physiologic things working in his favor in terms of he was younger, came to me relatively early, had the resources for therapy. And even though not the most sophisticated patient intellectually, you would think he was a crafty kind of guy. And I think he just kind of got it, even though he wasn't the most book smart guy. And his result, honestly, you can't tell the difference between his two sides. I mean, I very rarely hand out, M5s after a nerve injury, but I almost did. But I held to my principle: you can never be an M5 after a nerve injury, so I didn't give him an M5. But he looked fantastic. But it took 18 months to get there, and now he's golden. And it really is, I think, for patients. I'm awful at analogies, as you know, Macy, being in clinic with me. But I very much liken the tendon transfers to, driving a Honda, and the nerve transfers saving up to driving a Mercedes or your luxury car of choice. Because, you're still going to get to the same place. It's just a matter of whether you have the time and the resources to save up to get what I think is the best possible result. But not everybody is in that, even eligible for nerve transfers, which I think is the challenging part.
I think you should give yourself more credit, because I heard you say that analogy the other day and I loved it. And I told some of my colleagues at Milliken, and they're like, "Oh, I love that. That's great. That's really good."
Good. 1 on the scoreboard for me, 18 for Brogan.
I have to say, Macy, I have heard about this same patient at least twice before. So I'm not sure how many of these almost M5 nerve transfer patients are running around, but I like to hear about the same one over and over again.
There are multiple videos of multiple patients. I know we all take out our videos of our best patients, but I think it's important. You mentioned the prehab thing. I love prehab if we can make it happen. And sometimes the prehab is just being fortunate enough to have a therapy colleague. Usually it's either you, or in my other clinic, Jamie Findice or Kathy Dom or Lizzie Miotti in the clinic with me, just like, hey, I think
And that's
this
good
is
too. If you,
right. And just
right.
like this patient might be a good candidate. You may want to start on this now if we can.
So Macy, what is your, and I asked this question completely seriously because you may think I'm messing around, but what's your favorite thing about complex nerve clinic? Like, what do you enjoy about
Yeah, that's a
going to that
great
clinic?
question. Well, the medical assistant that works there brings really good snacks. And so that is primarily what keeps me there. But after that, wow, God, that is a great question. I love the way that Dr. D uses my services. He really values me as an OT. And I really feel like a valued member of the team, where he says, "Hey, this person could benefit from you. Can you please help make him better? Can you please help educate them on expectations following tendon transfer? Can you please evaluate him from a therapy perspective and tell me what I'm missing?" So I feel like every room I go into, like what I'm coming out to share, he values, and Dr. Brogan the same. So I love feeling valued. And I really love that each patient is like a puzzle piece. It's like, hey, what's working, what's not? How can we make him better? And so I leave clinic on Thursday nights being like, oh, my head's spinning, but I feel good. So I like it for a lot of reasons. And I hope that another therapist doesn't come in and swoop in and take it from me.
Oh, thank you to both of you. That was a wonderful holiday gift. I really appreciate that. It's a fantastic collaboration. I can't see the clinic being any other way. When Dr. Brogan and I designed it, we designed it heavily on what a lot of other centers do. And I think that we're even trying to take strides to make it even better in terms of, where we can go from here, really upping our education game and improving collaboration. So, this has been super fun, and obviously all of our complex nerve clinic collaborations are fun. I'll see you in a couple of days for it. But thank you for sharing your expertise with us today.
Thank you so much for having me.
It has been super fun. And just for the listeners, Macy and I grew up probably 10 miles from each other, and we sound exactly the same, don't we?
Do you think that I have a Southern accent?
No.
There was definitely a substantial amount of y'alls as soon as
Some
you got on
twang.
the episode.
Yeah.
When I hang out with Macy too much, the accent, it gets a little stronger.
Oh yeah. When I see my
Uh,
friends from home, it's real thick, y'all.
Chuck, I think you're like a chameleon, because I heard when you were hanging out with our fellow from last year, Elspeth Hill, I heard that your British accent suddenly came out. So
That did not happen.
All right, there are multiple accounts that may have happened. So,
All
all right.
right.
Well, you guys have a wonderful evening.
Thank you both.
Yeah, you too.
Bye-bye.